community care network, which is a touchy subject in some areas. It started as the choice program back in 2015 at the Phoenix VA because of all that publicity and things that were out there. So there was like Congress does, they just throw money at something and hope it solves the problem, right? Not necessarily the case. That's now evolved into Community Care Network, and now it's evolving into the Integrated Veterans Network, right? So when the law was passed, they actually appropriated $100 billion for outside care over a 6-year period of time. We still run into hundreds of people. Most of the urologists over at the AUA conference won't know that bill has passed, and they're troubled with how to get into it once they do find out about it. So what I want to know, or what I'd like to ask, and Dr. Henry, I'll ask you first, is that what is your feelings about how the implementation of community care is going? Is it useful to you, or is it a burden on your workforce and on your care for patients?
So I think, similar to our discussion on the clinical pathways, I think any program like this has advantages and disadvantages. I definitely utilize it. I mean, I will say our oncologists at Hines VA often refer patients through the community care network. Some of the resources that we can make available to veterans is care closer to home, which in many cases for veterans getting oncology care particularly is a huge benefit to them. So they're not having to come, hours from home or even an hour from home to get their care. And that can be really beneficial. I think sometimes the drawback for veterans who end up in community care pathways is we lose some of the standardization or some of the ability to kind of perform those quality measures. Like Dr. Solanke was referring to in the radiation oncology pathway, you have within the VA and within our group, we're trying to make sure veterans are getting consistent care. And once they're out in a community care program, we don't have the ability anymore to sort of monitor that or ensure that our veterans are getting the care that they might get if they were receiving their care at the VA. And in many cases, we have access to certain trials that may not be available elsewhere and that veterans wouldn't necessarily know about. So it's a little hard to sort of integrate the two pieces of that to ensure that veterans are really getting the best of both worlds as opposed to getting sort of disparate care depending on where they end up referred to.
And Dr. Farouk, in your experience with community care, do you feel as though you're getting all of the accurate data back that you would need when a patient comes back to you from the care? Because it was originally identified or designed to be just a stopgap, right? Yeah. Just to get him his initial care that he needs right now, and then have them come back because of all the other comorbidities you're dealing with on that single patient. So are you seeing people come back, or are you seeing the data come back with them and that sort of stuff?
Sometimes yes, sometimes no. I think it's a lot better than what it was when I first started. But I do think that we're able to attain that data if we're not very quickly. So I think it's much better now than it was before. And so I feel like we are benefiting from the program.
And are there recommendations on what you can say to people, say to the patients? I mean, we try to recommend to patients to always ask for whatever you can, just hand carry it back, because sometimes the internet's not working, right? So hand carry whatever you can back. And I mean, I hope as physicians, you all, and as nurses, you all ask them to do that. I was going to ask you, Kathy, what are you hearing from patients in their experience in community and coming back into oncology care inside the VA?
I feel like a lot of them over time become really great about navigating. At first, it can be kind of, trial and error. And this is what I really need from you. Can you make sure you get it to me? But in the end, we can kind of strike a pretty good come to a good place. Yeah. So, basically it's been going well. And I do stem cell transplant coordination. So I offer that up front. I tell them about community care options, and I tell them about our VA options. So we kind of, come to an understanding up front of what their options are and how it would look.
Do you know what, this is in the data, do you know what percentage of people are remaining in the VA for that stem cell treatment?
I, off the top of my head, do not know what percent. I could tell you that out of every 5 cases that I'd send, I say that 3 of them stay with the VA.
And, good.
Yep.
Good.
I think actually on the point of the data returning to us, one thing that I think is really interesting is in electronic medical record systems, we've, outside of the VA, had some significant improvements in being able to merge the ability to access other electronic medical record systems. So at Loyola, for example, we use Epic as a healthcare system, and you can access kind of this program called Care Everywhere, where you can see the records from a patient without anyone having to carry anything. And interestingly, in the VA, which obviously has a very extensive electronic medical record system, we don't have that integrated piece yet. So that's something I think would be another big leap in the community care program, is being able to just directly access those records electronically.
Do you, are you ever asked by leadership in the VA to make comments about the issues around community care, or around to give suggestions to make it better? Like, your perfect idea would be to be able to
I
communicate
think at a
electronically.
leadership level, certainly there's, opportunities. And so like our division leadership and our oncology chief, I think, participates in some of the discussions around that. But community care has its own also, whole integration of leadership and input that they're receiving. So I haven't personally had the opportunity to contribute suggestions. What were you going to say?
I think they just have town halls, and they really encourage us to come and be very vocal.
Yeah.
I will tell you, from VPCA perspective, we've been working very close with the leadership of community care, because while it's a good asset, we also believe that we can get the best care possible for prostate cancer inside the VA. I mean, you really can't beat it, right? And how you use the community care, we think, can be optimized a little bit. And there's some things, like you said, the electronic access to records or even images and that sort of thing. It's just software. You just have to get through it, right?
Yeah.
And it's those are things I think we can maybe help with, as far as we have a very good working relationship with those people, because it's, they just had a new leadership change. Dr. LaPuz has taken over, so we do communicate with him probably once a week type of thing. So it's very good.
The other piece when we're thinking of care in the community is, I think all of us try to, we have contacts at our community centers, and we try to, when possible, suggest patients go to folks that we trust and we know, so you can have kind of that warm handoff. And so they're not going out. So I think that for us, luckily we have a lot of, colleagues in the community that we can refer to within the area. That's a little bit more of a challenge in more rural areas where you may not really know a lot of the folks who are locally available to the veterans. So I think that is a source of trying to identify ways such that you have some measures that can kind of critically assess where a veteran is getting care is up to snuff, so to speak. Within radiation oncology, patients, in order to get care in the community, those sites have to be credentialed by the American College of Radiology. And so that's important. And so allows for us to try to make sure that veterans get great care.
Yeah. And that leads me to the next point about when we look at a lack of resources in the VA. When we're looking at radiation oncology, for example, there's only 41 sites that are internal to the 170 medical centers that have radiation oncology as an option. And I think now, with a lot of the ongoing non-invasive technologies and things like that, these other treatments that are coming on for, just all sorts of different types of cancers. But with prostate cancer, I think it's becoming another ready option. So how are you working, or is there any efforts, or how would you put efforts together to actually promote in those cities where there aren't radiation oncology capabilities at the hospital? How do we get the word out that we need access to these things?
Yeah, well, I think that's an important point. I think, the national office, Dr. Kelly, is working very hard to try to expand access to radiation oncology in some of these centers that may not have radiation oncology on site. One thing that helps us is there's been a shift as more and more data has come out showing that with improved image guidance and sophisticated treatment planning, you can reduce the overall number of treatments that a veteran needs for many different indications. And the real benefit of that is that's fewer trips to the center. So perhaps if it is geographically a little bit further, maybe it's a little bit more possible for that veteran to be able to get the care. And so that's one thing that's kind of in our favor within the VA, is that we have the ability to provide some of these treatments.